time as we invest in health system strengthening and so on. So it should become integral part of the international development agenda. I couldn't agree more.
I would just add, in addition to the health system strengthening and the educational at every levels, public health system strengthening has really been neglected.
Yeah.
And if there's one lesson from Ebola, it's the need to have resilient public health systems around the world. They're a best buy, whether it's for vaccine implementation or outbreak detection and response.
Yeah.
So I would feel a little bit more optimistic than your question sort of implied, but I know you don't feel. And that is, I think there is a growing awareness of this. And we mustn't just stop either at primary or secondary or tertiary. There has to be a career path for people who want to stay. I mean, I'm not a development expert, and there are many in this room who are, but it can't just stop at what has traditionally been PhDs and then nothing, because the brain drain will take people away from. So we have to think.
If you're good, you go to the West.
Absolutely, and that has to be. But give credit to many people in this room who I know who have played a major role in that. And as Tom said, CDC have played a huge role in this in training epidemiologists around the world, whatever we all think of epidemiologists. Yeah. Sorry, no, you were first. You were first. Sorry.
Young Gan from Korea, and I'm the president and CEO of a National Medical Center in Korea. And then I'm very much grateful for your great opinions. And then I'd like to ask you, panelists, all of you, that how we can improve health issues in terms of global health security by using ODAs, like from north to south, transferring all kinds of know-hows and to help them out in terms of funding as well as technologies. ODA, as you know that under OECD countries, you have DAC to improve ODAs, but I don't think they are doing really systematically in terms of health issues for the global health securities. What's your concrete ideas about that?
Peter, do you want to start with that?
We could have another session on that. Has ODA improved actually the health of the people in the world, in low and middle income countries? Overseas official development assistance. Thank you for the question. So, when you look at where the fastest and the greatest improvement in health has occurred, it has occurred in countries that have basically not benefited that much from this development assistance, particularly in Asia and in Latin America. However, I think that the time has come also to rethink that. I believe that many of the solutions or achievements in health will come from no longer just from the classic countries in North America, Japan, and Western Europe. That every epidemic will be an opportunity to learn that how we deal with chronic diseases. That's something that can, the ideas will come from all over the world today. So we need to share the wealth. Korea can share more of its wealth with countries that are less well off. But I don't think that the old paradigm where the problems are in a number of countries, what we call the North and the solutions in the North and the problems in the South, that is also changing. A lot of excellent research is going on today in countries that were not on the map, and we see that also when you look even at the world ranking of universities, Korea, Singapore, coming up in a big way, China and so on.
I also feel more optimistic about that. There is a tendency to be cynical and say, well, it's not working anywhere. Having spent the last 18 years living in Vietnam, having been born in Singapore when there were open sewers in the middle of what is now called the Central Business District, and that wasn't many decades ago, and countries in sub-Saharan Africa that are on absolutely the right trajectory, I think there is a tendency to be really gloomy about it, and I think that is in itself counterproductive. And so I think there is, whilst there's need for reform, as with WHO as we talked about, but there's not a need to just throw everything out and say none of it's working, because many countries actually are on a very optimistic trajectory, I believe. Tom?
There are important success stories, and it's important to learn from them, whether it's immunization, or training of epidemiologists or outbreak detection and control, laboratory networks. The African Society for Laboratory Medicine now has certified laboratories all over Africa. So there are success stories, but there are also failures to learn from as well. And one of the things that I think we need to do increasingly is have a level of contingent assistance. Countries have to create career tracks for people, or there's no point in trying to build a system when it's just going to collapse. Countries have to get the match that they choose between public and private sector in a way that's workable, so that if $5 out of $6 are being spent from poor people's pockets for private sector care, at least the government has to provide some level of oversight of that care.
I'm going to bring Hans in here because he's talked about this brilliantly often, that we talk about the so-called developing world as a group together when clearly it isn't. Hans.
And there is no definition. I came back from 3 months being main advisor on epidemiological surveillance in Liberia, and I can testify the great help we had from CDC, from WHO and MSF, that's still leading organization, and African Union now being so. What was the sad thing was the way development aid funding made work irrational. That's my reflection on it. The funding from CDC was to take care of the United States, and yet so great work outside. The only thing we criticized you for was we wanted more of you, and we wanted fewer for longer period. That's what we wanted, but you could do what you could within your situation. And WHO had a core budget which is it 12% or 14%, and they were dependent on sort of other money. It's not rational the way they are organized. The saddest thing was these Ebola treatment units, which was on aid money. There was no way we could stop them from being built in Monrovia. We knew 2 months ago there would be extra beds. There was not 2 beds per patient. There are 10 beds per patient, 20 beds per patient. And the government had tough times to convince the aid organization to stop building them. In the end, they were allowed to build them, and they inaugurated them, but they couldn't open them. It was a waste of money, and that couldn't be managed. So what I see,
But Hans, how did you might have known it was a waste of money, and then what happens if the epidemic had taken a turn that even you could not have predicted?
we could.
Where would you be sitting
No,
now?
we were gradually seeing where it was going. That was not the case. This was the stupid argument they had. The problem we had with data was that data were used for 2 purposes. Numbers were needed to be reported and communicated, mainly in the rich end of the world, and they were used for research papers, some which were useful, other which was not necessary. But data for management, we had very little. And we presented the data on the table. They just didn't want to listen because they already had the money. And probably the contracts were already written, so they had to be constructed. It was very difficult to have the data to work in a managerial way and to swap from this crisis management down to exactly what you say now, the finest and best epidemiologists, to what we need is Jon Snow. We just need new Jon Snows who do it in the same way and really understand it. So I would
I'm going to
think
stop you
that
there,
this
Hans, because we
control,
need other
the
people
control
want
is,
to ask.
it has to go out of aid money. It has to be global security money that secure this over the years into the future. Aid money is too unreliable.
If somebody could pinch the microphone. from
I
Hans,
just
'cause
would
I-
say, while the next person is asking, the biggest challenge in Ebola was how fast things changed. I went in August and September. Within 1 week of leaving, things were dramatically
Yeah.
different.
Yeah.
I went end of December. Within 1 week of leaving, things were very, very
Yeah.
different.
We had got, just before, after Tom was there, Peter and I were there, and it was dramatically different from when Tom was there, only actually I think 10 days before we
Yeah.
were there. Yeah,
So this goes
preferably not Ebola, but it could.
Actually, it's okay. So here's my question. So I'm a little haunted by the fact that it was 40 years when the global health community was first talking about Ebola, and we didn't do much. So I guess my question is there another virus that the global health community is thinking about at this moment that hasn't captured our attention and that we should be thinking about to get ahead of the curve?
I think we would all have a list for that. The list, I actually don't think the list is huge, to be
But
honest.
I think we'd
but-
all start with flu.
But there is a list.
We would
and
all start with
And we would
flu.
all start with flu. And I hate to go back to Donald Rumsfeld, but of course there's the knowns and there's the unknowns. And there are, in my view, a relatively small number of knowns that we do need to learn. One of the lessons, and one of the lessons for me, hate to mention Ebola again, is the demonstration that once you've got a vaccine on the shelf, don't just wait at the non-human primate level, make sure you've got the safety data if you're
Yeah.
likely to want to use it. So
Yeah.
the list for that is not that extensive in my view. Tom, absolutely agree. Flu for me remains
Yeah.
the big number one, but I could give you a list of
Yeah.
others.
And who knows what the next HIV will be?
Yeah.
And who
Or the
knows
next
how
SARS.
different the world would be today if we had recognized HIV decades ago and had containment.
Yeah.
And it's not only new organisms or microbes, but also untreatable, I mean, multi-resistant microorganisms. And
Yeah, we
that's
have not
part
talked
of
about
it.
drug
Yeah.
resistance, and in my view at least, drug resistance has to be put into the same
Yeah,
category
yeah.
as the emerging infectious
Yeah.
diseases. In my view, it will be the most important emerging infectious disease of the 21st.
Absolutely, and
century.
the triumvirate of risk is bioterrorism, because unfortunately the great tools we have that allow us to do things for good also would allow bad things to be
Where
done.
do you stand on gain of function studies, Tom?
Well, it's very clear that they have risk, and it's not so clear what the benefit is. So I would say
Yeah.
there are times when they should be done very, very carefully, but that risk-benefit ratio is something I think we have to recalibrate.
Because one of my the reason I asked that, one of my worries, gain of function studies is where you change a pathogen so that it makes it more transmissible, more
Yeah.
virulent. My worry is the global capacity for conducting surveillance at the level we think it should be, and even at today's level, I'm not convinced that's sustainable when we have to respond to every single flu H7N9 in China at the moment. We've got no idea if H7N9 is going to be a global threat or will just remain a relatively minor avian influenza that infects a few humans. And I think understanding the biology of that becomes critical. I don't disagree with Tom's risk-benefit discussion. Sir, and then come to you.
In the case of Ebola, there's no vaccine. But in the case of influenza,
Better just introduce yourself to...
All right, I'm
Just very
Tachi
brief.
Yamada.
Tachi Yamada.
I'm with Takeda Pharmaceuticals. In the case of Ebola, there is no vaccine. In the case of influenza, there was a vaccine. And this raises the question of global governance, because the vaccine that was available was basically nationalized in every country that produced the vaccine. Therefore, nations acted in their self-interest, not necessarily in the best interest of the world. And how is that prevented?
I'm afraid with only 2 minutes left of this session, it's going to be awfully challenging, but just I was very, very involved in which goes back now 8 or 9 years around the, as portrayed, the Indonesian Ministry of Health opinion, why should we share our flu viruses when you'll just sell us back a vaccine at cost price? I don't even within international health regulations and within the contract that was organised post-bird flu, I'm not sure still we've got that right. And that inevitably countries will go back to national interest when the threat really hits, inevitably. And that's where global governance comes in. We'll take the last question.
Coming back to the issue of surveillance, getting to zero, Dr. Annie Sparrow, I'm from Mount Sinai Hospital. There are parallels between the appearance of Ebola in West Africa and the reappearance of polio in Syria. And I say that in terms of governments tend to cover up infectious disease. We saw that in both countries. Guinea covered it up, Syria covered it up. We see these fragile health systems. One was neglected, one was destroyed. In terms of data, we have to get it in a timely manner. We have to respond to it. Here, the imperative, as I see it, is the opportunity, the imperative to invest in surveillance. We depended on surveillance for smallpox eradication. We depend on surveillance. And yet, we then depend on aid money, and we put money into organizations such as Save the Children Sierra Leone, which have neither the clinical capacity to treat Ebola nor the public health expertise to do the contact tracing, the prevention that is absolutely essential to get data in a timely manner and to convey it to respond. And that, I see, is the issue, because we are dealing with these are issues of global governance. This was a year where we saw the 2 public health emergencies of international concern. You need to deal with the government issue where they tend to cover up, and then to deal with the actual, how do you get that expertise on the ground to do the surveillance that we desperately need to address these.
I'm just going to take Chairman's prerogative and say I'm absolutely believer in surveillance, don't say anything otherwise, but unless we add response to surveillance, surveillance in itself will not solve the problem. We are going to have to finish there, I'm afraid. Thank you, Tom. Thank you, Peter. And the audience here, I'm afraid we didn't go to the social media audience. Key lessons to be learned, inevitably. Global governance, I think our view is a strong WHO remains critical to global governance, and we would do everything we can to try and enhance and support it in a positive way to make it stronger. Surveillance is critical. Emerging infectious diseases have to be put into the context of the society they're occurring in, the national systems we heard about, the non-communicable diseases and the endemic diseases that they are there in. And if we forget them, they will come back to haunt us in future. And with that, I'll close the session. Thank you very much. I'm staying around for a few minutes. I hope you've enjoyed it. I'm staying around for a few minutes. I'm not sure if Tom and Peter are, but...
Yeah.